Welcome to the Thyroidless Life podcast with me, Dr. Rebecca Warren. I created this podcast because I wanted to empower, educate, and equip women to not only just truly understand thyroid hormones, but understand their bodies and how to get themselves well. This is such a unique podcast because not only am I a doctor that's worked with women all over the world on reclaiming their health, but I've walked that same path as well. If you want more information about what it looks like to work with me, get my free Optimal Lab ebook, get plugged into my amazing Thyroid Inner Circle community, as well as join my newsletter, go to my website, drrebeccawarren.com. I am so excited for this episode and for you all to listen to it. I think it's going to be a major encouragement. It was for me. A lot of what we discussed is a lot of what I've been teaching for years. I've done with my coaching clients and especially in my Thyroid Inner Circle community. And it's something that I did when I was just a patient myself almost 2 decades ago. But it makes it so different being able to talk to someone that has spent 3.5 decades researching this, knowing this, and even implementing it himself with his own patients. This is going to be encouragement for a lot of you guys that are looking for answers and have felt very frustrated, had a very frustrating experience within the medical system, either hitting a dead end, not feeling heard, or just not knowing what steps to do next, especially for those of you guys that have to be on thyroid meds like those post-thyroidectomy. And when it comes to T4, T3 medications, I have heard so much misinformation being told to patients that are just, it's just misinformation. So this is going to be an encouragement for a lot of you guys with that as well. And it's just so eye-opening to start to understand how to navigate that medical system, especially when it comes to research versus your lived experience, especially again for those post-thyroidectomy. There's a few big things I took away from this whole interview talking to Dr. Bianco I want to touch on really quick. First is that when you are an active participant in your healthcare, when you are informed and you're asking questions and you're learning about your body, understanding your labs, and you go in and you really challenge your practitioner to work with you and to help you get well, not only does that have the ability to change the trajectory of your own health and your own life, but it can change the trajectory of how they practice medicine and even change the trajectory of research. Because Dr. Bianco was influenced and affected by the people that would come into his office and say, I don't feel well on T4 only. And it really changed his outlook and challenged him to look deeper. Now, I know for a lot of you guys, that is not an experience that you see going into your doctor's office. A lot of you guys are told not to ask questions, no, and the conversation shut down, and you guys already know what I'm all about. I'm a functional practitioner. This is what I help women do, but you also know I am a huge proponent of firing doctors that you're not able to go in and have shared decision-making together because your life depends on it. And I also know for a lot of you guys, you don't know where to start. But the truth is, you have to learn outside of the doctor's office, right? You have to get empowered. You have to get equipped before walking in there. And then hopefully over time, you don't have to become dependent on that medical system. You can use it for what it's worth. You can use it for what it's good at, the emergency care, keeping in check with your meds. And that's my goal. That's my heart. That's my calling in what I do through my Thyroid Inner Circle community and my podcast is I want you guys, if you have your thyroid, to do everything you can to not lose your thyroid. And if you've lost your thyroid, I want you to defy the odds and I want you to show them what it looks like to be well because you are advocating for yourself. Another thing, though, I want to point out, and you might notice it throughout the interview, I ask questions like about testing reverse T3 or suppressed TSH post-thyroidectomy. And the truth is there's just not enough proper research. So doctors like Dr. Bianco might be more conservative with those things because there's a lack of quote unquote data. And I don't want you to be discouraged if the research is like that, right? In his book, Rethinking Hypothyroidism, something that stood out to me that Dr. Bianco wrote it was towards the end of the book, as he mentioned, it took the American Thyroid Association over 50 years to get to a point where they're acknowledging, oh, some people don't do well on just T4 only. Some people may need T3, and it can completely change their life. 50 freaking years, which that affects me. Like I had my thyroid removed when I was 20. And if I did not challenge my practitioner and really go in there and have these conversations with them, I don't know where I would be at today if I, post-thyroidectomy, did not have T4, T3 when I needed it. I needed it. But it's so crazy for me to think over 50 years. And what's even crazier is that still to this day, there's doctors that are even resistant to acknowledging that. Research is influenced by interests, like what they're interested in. It's influenced by money. Unfortunately, it can be influenced by asking the right or wrong questions, which Dr. Bianco discusses in his book as well. So I always try to teach women in my community that I work with to live your life in such a way that they want to study you. And those of you, unfortunately, post-thyroidectomy, you are the study, right? Long-term, you are it. But that they want to study you, right? Show them what it looks like to truly heal post-thyroidectomy. Show them what it looks like to heal your thyroid. Even if you have those thyroid nodules, show them what it looks like to get your antibodies down, how to get yourself well. That's what I hope for all of you guys. And if you need that extra help, I'm here for you. And I hope that for you so that, fingers crossed, hopefully they start asking questions like, wow, this works. Wow, you're feeling better. You're losing weight. You're having this energy, that we can change what healthcare looks like for women. And how do we do that? Is by taking responsibility for our health, being well educated, and speaking up. Now, before I go into Dr. Bianco's introduction, I do want to let you guys know I have heard you. All right. I have multiple new services for those of you guys that might need my help. I do have my Thyroid Inner Circle community, and that's the best way to work with me. A lot of you guys think it's just group coaching, but it's not just group coaching. That is the one way that you can request consults with me. The group coaching part is to get deeper on the foundational things so that if you need to, you don't have to book a one-on-one consult being in the community, but if you need to, you can upgrade, book a consult, and have more one-on-one specific help. Community group is an affordable way to really start moving your health in the right direction. But we also have the ability where you can apply to do one-on-one coaching, which is my more intensive coaching program. You also have the option, if you don't ever want to see me, you don't have to. You have the option to order your own labs. You have the options to order supplements you may need. You even have the option to have a protocol sent straight to your email according to your labs if that's what you want. And the final thing I want to add about these service options for you is a new service called the Healing After Thyroidectomy Roadmap Consultation. That is a mouthful. But what that is I have had a lot of people, especially in my Facebook group community, that have just had their thyroid removed. I have people reach out to me that are thinking about having their thyroid removed. And I wanted to create a program where you get equipped, like a roadmap. Okay, I'm here now. How do I prepare for surgery and how do I heal from surgery? Or I just had this done. How do I make sure I stay right on top of things so they don't get bad post-thyroidectomy? Is even for those of you guys that might be like 7, 10, 15, 20 years post-thyroidectomy, it's going to be very focused on what research says about meds, where you're at, no matter where you're at in that healing journey, and how to get yourself well. I'm going to add a link. I'm adding a link to Dr. Bianco's Rethinking Hypothyroidism to my notes section. I will add a link to my website, drrebeccawarren.com, so you guys can go there. And if you don't know where to start, you also have an option to schedule a free call with my executive assistant, and Sophie can help you figure out what the next steps are, like where are you at, what program might work best for you, and help guide you and ask any questions you might have. So really excited. I wanted to put that out there. But let's go ahead and jump right in. Who is Dr. Antonio Bianco? He is a physician scientist working in the thyroid field. His work for over 35 years focuses on the diagnosis. And what they are is very, very important for all of you guys to understand. They are the enzymatic process that activates T4 into its active form of T3 so your cells can use it. It's how you feel and function well. So his work is paramount of importance. All right. He has played a key role in the research for that, which is important for thyroid hormone metabolism and action. Over 35 years, he's continued to work on these enzymes and has increased understanding of their molecular and cellular biology and gives insight into the variable responses to hormone replacement therapy. So he understands that T4 meds, T4, T3 meds, and TSH, right? Dr. Bianco has mentored more than 40 fellows and graduate students, and their work has been recognized in approximately 200 peer reviewed articles and lectures across the United States and worldwide. He joined the American Thyroid Association in 1987, and he served as president in 2015 to 2016. He did receive the John B. Stanberry Thyroid Pathophysiology Medal, which recognizes outstanding conceptual or technical research contributions to the understanding of thyroid physiology or thyroid disease pathophysiology, as evidenced by having a major impact on research or clinical practice related to thyroid diseases. All that to say, I'm so excited to share his information with all of you guys. Let's jump right in. I'm so glad we were able to make this happen.
Hi, sure. I'm glad to be here. Thank you.
Oh, awesome. All right. So I've got a few questions for you. And I mean, I read through your book. I've looked at your studies, really amazing stuff. And so,
Thank you.
but with your work and the things that you've done, like, have you seen studies and research looking at what you have been doing for the last few decades in regards to people without a thyroid? If there's a difference there that you have seen? I know you've seen patients without a thyroid, but
Right.
in the
So you mean
science,
patients that had total thyroidectomy as
total
opposed to
thyroidectomy.
patients that had Hashimoto's disease or something like that?
Yeah, yeah.
Well, I mean, yes. I think in principle, there should not be a difference because in Hashimoto's disease, there's an autoimmune process that destroys the thyroid. The body can't understand that that's your thyroid, so it starts to destroy it. And the surgery, the surgeon who goes with the scalpel and removes the thyroid out. So in the end, if the thyroid was destroyed by the immune system or removed surgically, it should be the same thing. However, what varies is a couple of things. Number one, the speed at which this happens. When you remove the thyroid, you had a thyroid, a functional thyroid, and then the next day you just don't have that anymore. So very acutely, very rapidly, the situation changed, and you're now placed on some pills. Now, in the autoimmune process, the destruction of the thyroid occurs very slowly. It can take months, sometimes years to be completely destroyed. So your body it adjusts to that destruction over time. So the processes are different. And in addition, surgically, when you remove the thyroid, there's no autoimmune process. So there's no autoantibodies circulating through your blood. And the autoimmune disease is, in fact, a disease. The patients that have autoimmune disease are more likely to have other autoimmune diseases as well. And you have those antibodies circulating. So those two processes are different. And I think this should be in the mind of everyone, mind of the patient that needs to understand these and the doctor when they attempt to treat those patients.
Absolutely. Something that's really interesting, because I've heard some other interviews that you've done as well, and you've talked about, because I would love to understand like TSH testing or
Uh-huh.
having it explained to my listeners. But one thing that I thought was really interesting that I've noticed with post-thyroidectomy men and women is that a lot of them tend to feel better on really suppressed TSH. And
Yeah.
I know you have concerns with that in regards to studies. So my question really quick about that is that because I myself, I feel like my TSH right now is at a point like 0.005.
Okay.
And I historically, that's where I've felt most energy and felt really great. So my question about that in regards to the studies, I know that TSH, they say like suppressed TSH can increase chances of HL fib or
Yeah.
osteoporosis. Are those studies also looking at what those levels of T4 and T3 are, or is it just only TSH at these numbers? Like, where's the concern there?
So the studies have not looked at T3, and I think
Okay.
that that's a problem
Okay.
because T3 is the active hormone, is the
Mm-hmm.
hormone that does stuff.
Mm-hmm.
TSH is just an indicator for us. It's like if you're
Mm-hmm.
driving your car and you look at the gas gauge. I mean, that's what TSH is. The indicator doesn't do much. What does is, the gas, which is
Mm-hmm.
T3, right? So unfortunately, those studies did not look at, many studies looked at free T4 levels, but again, free T4 is not the active hormone. It needs to be activated in order to become T3. Now, having said that, uh, I think that it's unequivocal that when you have a suppressed TSH for a long time, you increase the chances of bad things happening. And and as you mentioned, AFib or osteoporosis, those are not good things.
Mm-hmm.
So then, how do we put this into terms that the patients will understand? So assume that you're driving the speed limit of a town is 45 miles per hour. And there, here and there's a few accidents happening, but everybody drives at 45 miles per hour. Now, if all of a sudden the mayor says, no, you guys can now drive at 50 miles per hour, not only 45, you just increase a little bit the speed. It doesn't mean you, as an individual driver, will crash your car. However, when they look at the whole town, after 1 year, there will be more accidents just because you increase the little bit of individual drivers. Some people are more careful, are less careful. As a population goes, you will have more accident because you increase the speed. However, it doesn't mean one individual person will have and the same thing goes with AFib. When you lower your TSH in a population, you rest assured that you will have more cases of AFib when you lower the TSH. It doesn't mean that one specific person, if you're my patient, well, oh yeah, you're going to have an AFib the minute you suppress your TSH. That doesn't happen because AFib, you have to look at age. You have to look at other risk factors for
Mm-hmm.
AFib. You have to look at the whole patient, and you have to weigh the benefit and the dangers of risks of having a suppressed TSH. So, uh, having said that, in general, we should aim at not having a suppressed TSH. And why do I say that? Because when you have a healthy thyroid, your TSH is not suppressed. Your TSH is normal. So when you have hypothyroidism and the doctor wants to bring you back to the situation you were before you had hypothyroidism, you know, you want to bring back to the situation before. What was that situation? Normal TSH. So, you were not born with a suppressed TSH. Okay, I'm going to go back to what it was. So that's what should be in our mind. I know many patients tell me
Mm-hmm.
that. I even put that in the book. Oh, I
Mm-hmm.
need to have a suppressed TSH. And uh, I think the job of the physician, the doctor, is to explain this all to the patient, number one, and work with the patient in order to bring the TSH to a detectable level. How do we do that? uh, and managing at the same time how the patient's feeling, right? Because we're
Yeah.
not treating a number, we are treating how the patient is feeling. I mean, the symptoms of this patient. And then, therefore, I think one way to do this is to use combination therapy. Because when you
Absolutely.
do that, you lower your dose of levothyroxine and you introduce a little bit of T3. And studies have shown over and over again that you can have a normalization of T3 and T4 in the circulation and normalize TSH and minimize or almost eliminate the symptoms of ideally eliminate the symptoms of hypothyroidism. But again, this is a process that is going to take time. and it will require patience of both on the physician side and the patient side in order to adjust that.
Yeah, that's really awesome. And I have more questions about that T4 T3
Of course.
combination. Now, I'm curious too, because I mean, one thing that I've discussed with, because like you, like I have a lot of women that I've worked with throughout the years, and they're like, I just feel so much better unsuppressed. And I'm curious if there's a possibility. I mean, this is out there, this is theoretical,
Yeah.
right? I don't know if it's been studied, but now we've lost this organ system, this communication. There's always this constant communication between the pituitary and the thyroid gland, right? Hypothalamus, pituitary,
Yeah.
and the thyroid gland. Now, is there a possibility that now that we're lacking this organ, there can be an overcompensation, like a signaling dysregulation now that the organ is gone for why the TSH could be so suppressed? Like, is it possible that it's suppressed, but it's different because there is no organ there for that communication system?
We have no indication that that's the case.
Okay.
I think that what's happening is that so let me give you my idea on
Yeah.
this. So TSH is a great test
Mm,
to make the diagnosis of hypothyroidism. Of course, if your thyroid is no longer there, the TSH is going to go up.
mhm,
It's
mhm,
trying to stimulate something that's no longer there, and TSH is going to go up. So that happens in most patients. A very small number of patients have hypothyroidism without an increase in TSH. And those patients have what's called central hypothyroidism or secondary hypothyroidism, or maybe they're taking some drugs that prevent the TSH from going up. But that's a minority of the cases. And doctors should be aware that this exists, and they are, and work around this. But let's talk about the bulk, the majority of the patients. When your thyroid doesn't work, TSH goes up. And that's very sensitive. That's great to make the diagnosis. Now, when we start treating patients with levothyroxine, the idea is, okay, TSH was normal, now it's high. I'm going to give levothyroxine to the point that I'm going to bring the TSH back normal again, and everything is going to be okay. It well, the only problem is the thyroid makes two hormones, T4
mhm,
and T3. And when we treat patients with levothyroxine only, we're treating with only one hormone. So it's not okay to rely on TSH only when we are treating patients with levothyroxine only.
mhm,
That's my point. And I think
mhm,
that even though we do that, it works for most patients. For a substantial number of patients, that is not okay. So
mhm,
just looking at the TSH might not be the thing to do. Well, I think we need to look at TSH, we look at free T4, T3, and how the patient is feeling, symptoms, and equate all of this. And so the TSH becomes one more information, but
mhm.
not the critical information that's going to drive everything.
Now, with your work, because you focused a lot on the deinases, D1, wait, D2, right?
Yeah.
So, what I thought was really uh, eye-opening, I wish I would have known this when, I was 20 years old, is the reason why TSH is not a good marker, is it because it has its own D2 pathway in the pituitary? Is
Correct.
that what it
Yes.
comes down to? Could you
Yes.
explain that for my
Of course.
listeners?
Of course. So T4 is a prohormone, right? T4 needs to be converted to T3 in order to gain, but in order to do something, in order to resolve symptoms. T4 does not resolve symptoms by itself. It needs to be converted to T3 in order to resolve symptoms. Okay, how does that happen? There's these enzymes. There are little engines in the body that can rapidly convert T4 to T3. Now, as the patient takes a tablet of levothyroxine, a lot of these little engines are making T4 to T3 conversion to supply T3 to the blood so that all the organs and tissues are benefiting from having an active hormone, T3. In the pituitary gland, there's also the same little engine that converts T4 to T3 and tells the TSH that there's hormone coming into the body. Now, we always assumed that these two pathways were in sync, were working together. So whatever is happening in the pituitary gland is happening in the periphery as well. However, that's not the case. We have very conclusive, objective evidence that the pituitary gland works, has a mind of its own. The activation of T4 to T3 in the pituitary gland is super effective. Is really, the pituitary gland is very good at converting T4 to T3 all the time, non-stop. But when you look at the other, or the periphery, no, the periphery functions less effectively. And as you increase the dose of T4, the more T4 you give, the less T3 you're making. It's the body's defending itself, it's protecting itself against an excess of T3. So therefore, the realization that these two pathways are not synchronized, it's really important. And that tells us that we cannot rely 100% on the TSH, because we need to look at what's happening in the pituitary gland, but also look in the periphery and to see how much T3 is in the circulation. We have many patients, as much as 15% of the patients, in which the T3, even though the TSH is normal, the T3 in the circulation is below the normal range.
Mm-hmm.
I mean, how can we imagine that we are doing a good job if the hormone that actually resolves the symptoms of hypothyroidism is below normal? And just because the TSH is normal, the TSH does not resolve symptoms of hypothyroidism. And that's important realization. TSH is important. However, we need to look at also at the T3 levels, which are the hormone that actually resolve the symptoms.
So why do you think, because I let my I have my newsletter, people that are part of my newsletter, I was letting them know you were going to be on my interview, like I was going to interview you, you're going to be on my podcast. And I had a few people reach out to me, and you have stories in your book where patients are like, I don't feel good. But
Yeah.
what was really interesting, someone sent me a message, and I mean, this person is symptomatic. This is a male. It was talking about like I go between hyper and hypo symptoms. I'm
Yeah.
65 years old. I'm on a suppression dose of levothyroxine, and my endocrinologist will not even measure T3. She says that it would not change her influence on her treatment. Is she right? Like, what can I do? And I had another woman that's like, I had my thyroid removed 2 years ago. I'm on, T4. My endocrinologist will not order these labs. I've gained
Right.
40 pounds. I'm exhausted. What? Why? Why is this why is this happening?
Well, because that's how we learned in medical school. That's how I learned. Okay. In the 70s, uh, there was the idea that we would treat patients with levothyroxine, we would normalize TSH, and the symptoms will go away. And so we evolved, knowledge in this area evolved so that that method became the standard of care. And so if you read any book from the 70s, the 80s, the 90s, uh, this is what the book said, not only the books, but the clinical guidelines, because it does make sense in the minds of the physicians that when you have a TSH that's abnormal, if you normalize the TSH is okay, everything goes back to normal, and you have some T3 in the circulation. Uh, this is how I learned. Okay, until and if you read my book, until 10 or 12 years ago, that is what I was going to tell the patients. This
Mhm.
I lecture for
I mean, you did. You admitted in your book,
decades.
you said you were that doctor.
Exactly.
Yeah.
However, we need to realize that we discover new things now. I mean, not only from my laboratory, but other laboratories all over the world have discovered other things that put in question that dogma that just the TSH will tell you everything you need to know about the treatment of hypothyroidism. And now we have to evolve.
Yeah.
This is what we do. Societies, professional societies should teach the physicians, teach their members that there's this new work that's being done. This is why I'm talking to you. I mean,
Mhm.
my hope is that I can spread this new information that's happening, that it's published, and the people listening to you and doctors or maybe patients will start thinking about it and perhaps change the way they approach hypothyroidism.
Yeah, I mean, there's two different things. Like, I mean, I think I highlighted like 60% of your book because I was like, oh, yes. Oh, man, that makes sense. I feel this way. Because again, I felt all this. But there was two different things that stood out to me that you talked about. Was number one, I was very shocked that you had talked about how your colleagues, like, they wouldn't take like patient preference wasn't a part of
Oh
the
yeah,
shared decision making process, which was shocking because that's part of shared decision
right.
making. And the other part was how you talked about, especially with T4, T3 combo, how it took like 50 years for eventually, like, I think you were talking about the American Thyroid Association to kind of, get behind this and be open to it. So that's, with that information, like, what would you recommend? Let's say you have your aunt, someone you love, right? And
Yep.
they have this issue going on, they have these symptoms. Like, what would your recommendation with your background and the research you've done? What would you recommend they do if they were in this situation, like symptomatic? Like, where should they start to
Okay.
kind of change this?
So I think that if you're diagnosed with hypothyroidism, the first thing you do is make sure you have hypothyroidism, and then you start treatment with levothyroxine. Levothyroxine has been shown over and over again to resolve symptoms of most patients. Okay. If you're lucky, you're fine, and then you don't have to worry about it. You just need to think about it every time you go to the pharmacy, get your tablets. Now, if you're part of that minority of the patients that remain symptomatic, even though perfectly treated, but the symptoms are still there, not as much as they were before, but still a little bit of symptoms, what can you do? So the first question is there any other condition that could explain these symptoms? Uh, for example, menopause is, or
Mhm.
the perimenopause is a very common condition that leads to symptoms that are similar to hypothyroidism. So, dry skin, hair is not doing well, constipation, the mood is not good, you're tired, low energy. So these symptoms are really indistinguishable between the menopausal syndrome and hypothyroidism. So make sure that's not the case.
Mhm. Mhm.
Like that, there are other things, diabetes, some vitamin deficiency,
Like
anemia,
iron, yeah.
iron. I mean, there are a few things that could cause these symptoms and had nothing to do with your thyroid treatment. Okay, so first of all, let's eliminate all that. So,
Mhm.
number one was make sure you have hypothyroidism. Number two is eliminate other reasons for why these symptoms could be there. And if you eliminated everything and you still are not doing well, we the only thing we can do, I mean, right now, we don't have a lot of things to do. The only thing is to try combination therapy with levothyroxine plus T3. There's nothing else we can do.
Mhm.
And because we know levothyroxine, it's not ideal, because we know that T3 might be low, because we know we can't trust fully TSH. So for those patients that remain symptomatic, what we do is we lower the dose of levothyroxine a little bit, make room to introduce the T3. So you're going to elevate the levels of T3 a little bit. Everything needs to be within the normal range, and the physician will know how to do this. Your TSH will remain the same. T4 is going to be slightly lower. T3 is slightly higher. And you can try that for 6 months up to a year. Some adjustment of doses. There's a lot of work involved behind of this. I
Mhm.
say it in 30 seconds. However, we need to make sure that you're taking, once a day or twice a day, T3. There's a protocol for doing that. But if you do that, more than 50% of the patients feel better
Mhm.
afterwards. There will be still some patients that don't feel okay. So then the physician needs to think a little bit more, do more investigation. But the majority of the patients, more than 50%, will feel better with that approach. And that approach is not crazy. that approach actually is recommended by, as you mentioned, the American Thyroid Association. If you read the guidelines, that's exactly what it says.
Mhm.
It says, and the way it's framed, it caused a lot of confusion because the way it was framed in the guidelines, it says, oh, you shouldn't do that as a routine. Oh, yeah. What does that mean? It means that you shouldn't do that for every patient that comes to your office. You can't do combination therapy. You shouldn't do that. Okay, that's okay. Yeah, we should do only for those patients that remain symptomatic. And after you excluded all the other possibilities. So I think that if you read, so the American thyroid, the European thyroid, the British thyroid, the Society for Endocrinology in Europe, four major endocrine societies have already published guidelines stating that that's how we should proceed.
Yeah, that is amazing because I think that's just so important for like patients to know that that is an option. That's how it
Yes.
should go. And what I thought was interesting though, but in your book, because you've mentioned it here, like a minority of the population would need combo therapy, but a minority, conservative numbers is what, 10 to
Oh,
20%,
oh yeah, it's a lot.
which is 2
Exactly.
to 4 million people, that
Yes.
conservative number, maybe
Yes.
even more. So
Yes.
even though that when I was reading it, I was like, let me go calculate this really quick. I'm like, that's
Yeah, no.
millions of people.
Yeah, it's a minority, but hypothyroidism is so prevalent,
Yeah.
prevalent in the population that, 10%, it ends up being millions of people.
Yes. Well, I would love to talk more too about the work you've done with D2 and polymorphisms. Like
Okay.
what like what how is my first question is if you have a polymorphism in your D2 pathway in the peripheral tissue, would you also have it in the pituitary or is it separate?
No, it's
Um,
everything. So
everything.
if you
Okay.
have, it's a genetic polymorphism.
Mhm.
So let me just explain. So the D2 pathway, this little engine, it's made up by amino acids, right?
Mhm.
So then in some patients have a change in one amino acid at position 92. So there are 100 and plus amino acids. At position 92, there's a change. And instead, normally there's a amino acid called threonine there.
Mhm.
And in some patients, there's alanine as opposed to
Mhm.
threonine. It's just a little change. But that change is important because it transforms D2, this enzyme, in a slower enzyme. So that means that whoever carries that polymorphism, that change, makes less T3 through a given amount of T4. It's so if you think, well, how's treatment of hypothyroidism? Well, treatment is take a tablet of T4 and then wait until your enzyme converts T4 to T3. Now, if you have a problem in your enzyme, in your little engine that converts T4 to T3, it's converting less, you're going to have a problem in the amount of T3 that's being generated every 24 hours. And that's important because T3, again, is the hormone that resolves the symptoms. So, uh, so this change is actually very, very prevalent.
Mhm.
About 50% of the population has at least one allele, meaning, so we normally have two alleles, like one from
Mhm.
the father, one from the mother, two copies of the same gene, and the people can be heterozygous or one good allele, one bad allele, or have both bad alleles. So at least 50% of the population has at least one of them, and that's a problem. Now, why do we know it's a problem? Well, we made a little mouse
Mhm.
that has that polymorphism. And in studies in mice are easier to interpret because those mice are identical to each other, right? They're called congenic. They're very similar, identical. The only thing that changes is that amino acid. So it's if they are identical in everything else, it's very simple to see the differences because the only thing that's different is that polymorphism. And then we saw those mice behave a little bit as hypothyroid patients. They don't like to move around. Uh, they have not a lot of energy, a lot of interest. They actually have hypothyroidism.
Hmm.
Now, why is that not so straightforward, the translation of those findings to patients? Because patients are not identical. I mean, it would be as if we were just dealing with twins, identical twins. That's not the case.
Hmm.
Each patient has uh, its own history, its own genetic background. So, in some studies, it has been found that having this polymorphism is not good for your treatment of hypothyroidism. Whoever has that polymorphism requires the combination of T4 to T3. That has been found in some places in the UK. Now, in other places, in Europe, they didn't find that association. Therefore, what we see is that uh, depending on your genetic background, depending on where you live, maybe on other factors that we still don't understand, that polymorphism becomes more important or less important. And looking at that, what we did in our lab again, we took these mice with the polymorphism and we crossed them with another mouse. Mice, you have different types of mice.
Hmm.
So we moved that genetic defect to another mouse strain, and we found that the effect of the polymorphism is much more impressive. So, meaning, what does that mean? It means that the polymorphism doesn't work only by itself. Its relevance has to do with the other genes that are around. So that starts to explain why different people, different races, different geographical populations could uh, behave not so consistently as we would expect.
And the other thing with that, could it be also because in your book you talk about how the thyroid gland itself can make up, like it can
Oh,
significantly
yes.
make up the T3,
Yes, yes.
right?
Oh, yeah. When you have a healthy thyroid, you don't have to worry about the polymorphism
Okay,
because the
because it,
thyroid makes up. So, because people, when we started this story with the polymorphism, people say, well, but why you only think it's important after you have hypothyroidism? Yeah, because before you have hypothyroidism, the thyroid compensates. The thyroid's not dumb, it's smart. So
mhm,
if you have a problem in conversion of T4 to T3, the thyroid will just make more T3. And
yeah,
we know that. We did that. So the problem is when you have hypothyroidism, you lost that compensatory mechanism.
mhm,
And then you're all left with a faulty enzyme. You have an enzyme that's supposed to convert T4 to T3, but it's not working very well. It's a lazy enzyme.
yeah. So that, I mean, that's really important for those without a thyroid because now
Yeah,
they've lost their
that's
like
correct.
the ability to like compensate for this
Exactly.
issue, which would make
Absolutely.
sense why this could be such severe
That's
symptoms.
exactly right.
Yeah, that was shocking to me because, like, I feel like historically, before I became a doctor when I was a patient, like, I was just told, like, "Oh, if the thyroid does make, it's very little." So that was shocking to me to read, like, "Oh, no, it's not just very little, it is stepping up to the plate."
Right. It's adjustable. It's not, it's about 20% of your daily production. And plus, it's adjustable.
Mhm. Which we lose
Y-
post-thyroidectomy.
Exactly. We lose that.
Now, another interesting thing that was, like, very, like, stood out to me in your book when you talked about these polymorphisms is finding similarities in people with, like, Alzheimer's, dementia. Can you talk about that
Sure.
with
So,
SD2?
so this change in amino acid, uh, so proteins are folded.
Mhm, mhm.
Proteins are like maybe if you think of a flower with all those petals. I mean, they have a 3D structure, right? They're not a flat thing. They have a 3D structure. You should think as a convoluted uh, uh, structure. All these amino acids, they have intrinsic relationships with each other. Now, if you change one amino acid, what happens is that the folding of that protein changes, and we call it a misfolding. So it's sort of a little bit warped. the protein becomes a little bit warped. The cells, our body doesn't like anything that's not in shape. So it tries to get rid of this. In fact, the body tries to destroy that misfolded D2, pushes it to different areas of the cell. Normally, it's a normal D2 lives in a place called endoplasmic reticulum, very near the nucleus of the cell. But the misfolded, the polymorphous D2, the cell pushes it to the Golgi apparatus. The Golgi is a little bit further down from the endoplasmic reticulum. These are different components of the cell. And it generates what's called stress for the cell, activates pathways that are trying to get rid of this misfolded protein. So the cell doesn't like this. And as it turns out, that's exactly the same, a very similar mechanism that you see in neurodegenerative diseases like Parkinson's, Huntington's, Alzheimer's. In all of these proteins, in all of these diseases, you have cells in the brain trying to get rid of misfolded proteins, proteins that are not properly compacted or folded. So we had the idea, so, well, since this is misfolded, it's causing stress, maybe we should look at, is it more, do patients that have this polymorphism, do they have more Alzheimer's disease? That was basically the question we asked. It's tough to do those studies because you need longitudinal studies. You can't do just a cross-sectional because it's not going to be ideal. So we were lucky that we had access through Rush University here in Chicago. They followed thousands of patients in a longitudinal way. It's called Healthy Living Project, in which they just follow a large cohort, maybe 4,000 or 5,000 patients through their senior years. So that seemed to be ideal. So we looked at their database, we did some studies, and we saw that as they grow older, year after year after year, we could count the number of patients that develop Alzheimer's. Okay, then we split that population in those that have the polymorphism, those that don't have the polymorphism. And we saw that those that have the polymorphism develop more Alzheimer's disease than the ones that didn't, over 10, 20 years. And I think that's really important. Now, we saw the association between the polymorphism and the Alzheimer's disease in African Americans. We didn't see in European Americans. That could have a number of explanations. We know that African Americans are more, they have a higher prevalence of Alzheimer's disease. They have other risk factors. So maybe, the effect of the polymorphism is so small that needs to be in conjunction with other risk factors to be fully manifested. And goes back to what we were talking about, the genetic background. The relevance of this polymorphism really depends on the overall genetic makeup of that patient. But I think and then we actually reproduced the same findings in a different population in Michigan. And so we had two populations, and in both populations, we saw that association with African Americans. And I think that obviously it's one study. We need more studies to reproduce these findings or not reproduce. So we need more people looking into this. But it tells me that having the polymorphism not only can impair your ability to restore euthyroidism, because the enzyme, it's a lousy enzyme, generates less D3. That's the immediate consequence. But the long-term consequence is that you could have some stress and inflammation on your brain. And accelerate cognitive loss in these patients.
Oh, I mean, I think between reading that in your book and then there was the part where you were explaining with the mice and how you were like, I think it was like the hypothyroid mice and they weren't showing these signs of like symptoms of hypothyroid, but then you looked at other things like the mice wouldn't get on the wheel or the
That's
mice
correct.
wouldn't, you
Exactly.
know, like they were like essentially like the mice were like depressed.
Exactly.
And yeah, for me, like I've gone again 20 years, I've gone into hypothyroid state and I know when things are off because I'm healthy, I'm overall well, but if I go hypo, I'm anxious.
Yeah.
I'm depressed and it feels like it's all in your head. Like, what's wrong with me? When it's like, oh my gosh, like your brain is so highly dependent on this T3 and these conversions and D2.
Yeah.
I think a lot of patients struggle with that too.
No,
Like, wow.
absolutely. When I saw those results, I mean, I remember Barbara Bocco she was a postdoc in my lab, and she was studying that mouse. And when she brought me the results of the wheel, I mean, they just
Mhm.
don't go on the wheel. I told her, I can't believe that. You have to do this again because I want to see this repeat. Maybe there was something happened. We actually thought the racks in the animal facility that hold the cages where the mice are, maybe they were favoring one side. So I told her, scramble the cages, move them around, see if there's anything that's causing this. And no matter what we did, the results were the same. It's just amazing how they have poor motivation to do things. They have depression, they have anxiety.
Yeah, and for a lot, yeah, and a lot of the women that, and I'm sure with you as well, like it feels like, okay, I'm hypothyroid and now I'm depressed, now I have all these
Yes.
things, but seeing like that, like when I read that in your book, it was like, wow, you identified something that I feel for a lot of patients, they can't explain, they can't identify in themselves. Like they think
Yep.
it's something separate than being hypo. They just think like, oh, I have this other thing, which like, no, because they think hypothyroid is just like, I'm not losing weight or my
Right.
hair, when it can literally just all this mental
It's a lot of
health.
yeah. So you have cognitive issues. You have with your memory and
Mm,
you can't manage things very well. You're forgetful. You have mood issues in which you might feel a little bit depressed, anxious, and you have metabolic issues,
mm.
which is your cholesterol could be slightly higher. You have a hard time losing weight. This losing weight story is fantastic because for decades my patients would come and say, I'm hypothyroid. I can't lose weight. I said, that's not right. I mean, your TSH is normal. So I would
Mm,
just explain the lecture. I would just give the lecture.
yeah.
Normal TSH, you should be fine. Maybe you're eating too much. You have to cut on your calories. And, patients, they're nice folks. So they would smile, but I know in their mind they were thinking, this guy doesn't understand what I'm going through.
Yes.
Until we did the study and we compared patients with a normal, they're being treated with levothyroxine, have a normal TSH, levothyroxine, normal TSH, they weigh 10 pounds more than
Mm,
a matched control. So we had two populations. One population of hypothyroid patients on levothyroxine with normal TSH. And then we have a control population with the same TSH level. Both have the same. They have the same age, same ratio of males and females, same ethnic background, everything the same. They weigh 10 pounds more.
like there's going to be women listening to this. They're going to be like, I knew it. I knew something was wrong.
Right.
Because I
Right.
mean, and I think I heard you in an interview say that, like, you even talked to some of your patients about calories, which is what happened with me when I was hypo. I was doing CrossFit. I was very
Yeah.
restrictive in my nutrients.
Yeah.
And I went to my doctor and he finally was like, well, do you understand calories in, calories out? And I'm like, I'm eating like
That's exactly.
900 calories. Yes, I understand calories
Yeah.
in,
You have
calories
no
out.
idea the number of times I told my parents the same story. And I feel bad.
Yeah.
because I should have known better. I mean, I think
Yeah.
that I still beat myself in the head. Why? I mean, because I study this thing, and this is I'm supposed to be to understand about this, and it
Mhm.
took me a long time to figure this out. I mean, to really sink in, and what are we doing? First of all, I'm telling something to the patient that there's no evidence. I'm saying, oh yeah, if you have a normal TSH, you should not gain weight. Well, what's the evidence for that? Zero. I'm just repeating what I learned. My professor told me, so I'm repeating. Number one, that's
Mhm.
without even questioning. Number two, now we have the study, and we know that better. And I think that we should, again, doctors should be educated, should be updated. I mean, it's okay. Before the study was, study wasn't there. So,
Yeah.
it's okay, whatever you said. But now that the study's published, we should try to update ourselves and upgrade our conversation with our patients.
Yeah, I mean, I hate that you did that, but because you did that, you are saving lives, literally, with the work that you're doing. So I do appreciate that you were willing to adapt because
Oh,
what you
yeah.
do is life-changing.
Why not? Yeah, why not? I mean, if you're a scientist, that's exactly what happens. So you discover new things, and you have to change. When we start, you have a hypothesis, right? So everything we do is to test that hypothesis, and sometimes you test it and you confirm the hypothesis, and sometimes you test and you reject the hypothesis,
Mhm,
and you have to report both of them, and
mhm.
then formulate another hypothesis. So I mean, that's a normal exercise for scientists. There's no, I just regret that it took me a long time.
Yeah. I just wish more like because I'm in a smaller city and I know this is going on. Like I listen to researchers, I write studies. I've done this for over 20 years. I needed to save myself, right?
Right.
But it's like, and then your chronologist down the street is saying stuff that I'm just like, what?
I
Like,
know.
I wish we could be more open
I
to
think
that.
that podcasts like yours,
Yeah.
it's a good way. I mean, the book, I
Yes.
really
Yes.
don't. I mean, this I sort of write more scientific papers than the
Hmm.
book like I wrote for patients, but I think that that's the work that should be done. And again,
Absolutely.
professional societies should be doing that with their members.
Absolutely. Now, one thing I do want to touch on, because you were talking about like, okay, the whole weight gain, because then what essentially can happen, especially with women, is now they're gaining weight because they're being told their TSH looks, good.
Right.
And then what they will do is now go into calorie restriction. And that's going to cause a vicious cycle, right? Like it's going to, do you have any information on that? Like calories in regards to affecting like thyroid hormone output or conversion going on there?
Yeah. Well, you touched a uh, very important thing, which unfortunately we don't have a lot of data.
Mm,
You are correct. That conversion of T4 to T3 is accelerated by calories. Let's
mhm,
put it that way. If you stop eating, if you fast, that conversion of T4 to T3 drops
mhm,
very rapidly. Your T3 levels drop very rapidly. T3 stimulates the metabolism. If you're not eating sufficiently, the body will try to protect itself by
mhm,
decreasing, you just take the foot out of the gas, right? You produce less T3. Now, what you said is, so if you are uh, overweight and you cut down the calories, and the only source of T3 is that conversion of T4 to T3 because you're hypothyroid, you don't have a thyroid. You're going to drop your T3. That's correct. Will that have an impact on the overall treatment of hypothyroidism? For example, are you going to be more depressed? Are you going to have more mood swings? I don't know. I think
mm,
I think that we should do a study about it. I mean, I don't
mhm.
know any studies that have been done in that regard. I think it's a very, very good question that needs to be addressed. It, you know, it makes sense what you're saying. I mean, I think that it could be that you're disrupting even more your treatment of
Mm-hmm.
hypothyroidism, but right now we don't have data to
The
support.
science, yeah.
But it does make
Yeah.
sense.
I just hate it that when women they essentially start to beat up their own bodies because they are like, why am I not losing weight? Why don't I feel more
Correct.
energy? So they restrict, and especially protein, it's a
Yeah.
big issue there. Now, one really quick question about with the deadenase like D2, we know polymorphisms affect it. Have you seen like things that can affect it significantly in its efficiency, like insulin or amino acid deficiencies or mineral deficiencies? Like, are there things environmentally that can, like lifestyle wise, that could affect how that presents itself?
Uh, well, that we asked that question in a large setting of patients. We
Mhm.
looked for a lot of variables. Like we use a database that's called NHANES. This is a federally funded project that study the lives and the health and the eating habits of Americans overall, all over the country. So they have a large data set and they have a lot of information. We looked at being divorced, your marital status, you have a dog, I mean, how many children, where do you live? We looked at, is there any condition that would correlate with the conversion of T4 to T3? And the only one that pops up was uh, calorie intake. We
Mm,
know that caloric intake is a very strong determinant of the conversion of T4 to T3. That doesn't mean there aren't others. Maybe there are others. We still don't know
okay.
anything other than caloric intake.
Okay. That's good to know, but that's something we can look forward to
Yeah.
hopefully in the future studies.
Yes. Yes.
Now, one thing I would love for you to touch on that it's also touched on in the book. How about T3 safety?
Oh,
I loved hearing your thought process in the book of like, wait, let me look into
yeah.
because I do hear that a lot. Well, not as much as I used to, but or doctors would be like, oh, it's T3,
Oh,
it's
yeah.
just not safe
Don't
to
touch it.
use.
Oh,
Yeah,
oh my
yeah.
goodness, it's going to
Like it's
explode. Yeah,
dangerous.
it's going to kill
Yeah.
everyone.
Yeah.
Oh, this is how this is, when I went to medical school, Uh, we would even, oh, that doctor, he prescribes or she prescribes T3 to their pet. Oh my goodness.
Oh my gosh.
And
Yeah.
then when I went to, I gave a lecture, I put this in the book in DC several years ago. I mean, maybe 15, 20 years ago. And in my lecture, I talk about T3, and someone else, another speaker asked,
Yeah.
could you show of hands of how many of you give T3 to patients? One or two guys came up. During the interval at the coffee break, they all came, oh yeah, we give T3. I mean, so we just didn't want to say it in front of everybody else. So I had a colleague
Oh.
that said he gives T3 to patients. And then, we work in an academic setting. There's always a trainee, a fellow that's learning. And, but this colleague of mine, he tells the trainees, don't tell anyone that I give T3 to the patients, but
My
I do.
goodness.
So there's a tremendous peer pressure not to
Mhm.
give T3. So one of the reasons is T3 is dangerous. If you give T3, you're going to immediately increase the chance of atrial fibrillation or osteoporosis. And all along, I thought that was based on fact. So a few years ago, I had a fellow working with me and said, well, let's revisit this. I mean, can you pull up how many papers are shown? Zero.
Mm.
Zero. There's not a single paper, not a single study, not a single document showing that if you treat someone with combination therapy, you're harming that person as long as you give the right dose. I mean,
Mhm.
because everything that has been associated with T3 has also been associated with T4. You can cause atrial fibrillation by giving T4. You can cause osteoporosis by giving T4. So, of course, you have to give the right dose. The same thing with T3. It's really, and In the contrast, there are lots of studies showing that T3 is safe. Thousands of patients have been studied here in this country and in Europe, and we have not been able to find anything. Having
Mm.
said that, I have to say that there is one study that was published in Korea, a recent study, in which they did find an association with combination therapy and poor outcomes. I think they found myocardial infarction and they found stroke associated with T3. Now, the problem with that study is that we don't know how much T3 was given.
Mm.
We don't know the TSH levels. We don't know the T4 level. We don't know the T3 level. There's nothing there. So I mean, for all I know, those patients could be receiving a large dose of T3.
Mm-hmm.
I don't know. So for you to question something, you should say, here's the study, normal TSH, normal everything, but T3 is causing that. No, we don't have that study. And at this point, I would say T3 is perfectly safe as much as T4, given at the right dose without suppressing TSH. And I would think that you should always also exclude from that population pregnant women, because we just don't have the data on pregnant women. We should exclude children from that list as well, because we just don't have data on children. And we should also be careful with patients that have cardiac conditions, heart conditions. I mean,
Mm-hmm.
if you have unstable angina and you start taking T3, probably that's not a good idea. So if there's any question, we should always check with the cardiologist of that patient in order to make sure that we're not adding another risk factor for a poor outcome. But having, with these limitations, T3, there's no reason not to prescribe T3 at this point.
And I love to hear that. Like, again, I'm going to be on thyroid meds for the rest of my life. But in the last 20 years, I've had to try, like, I was my first few years post thyroidectomy, I did fine with
Uh-huh.
Synthroid, and then I didn't. And I
Mhm.
needed to change things up. So I've tried T4, T3, I've tried natural desiccated thyroid. I used to be a hardcore, like just natural desiccated thyroid, but I've realized that by utilizing T4, T3, you can just tweak it according
Yeah,
to what your body
that's exactly
needs.
right. Exactly.
And I like that a lot.
You can customize.
Yeah. Now, I did want to ask something really quick about the D2 polymorphism. Do you recommend patients get that tested to know? Like, is it worth knowing or no?
I don't think so.
Okay.
Just because we still don't have enough data. I mean, because I like to tell patients something based on real data. I mean, if
Mhm.
I
Mhm.
if there's a day that I'm going to be able to say, you have this polymorphism, therefore I know for a fact that this is bad for you. So I don't want to. I made so many mistakes in the past that I want to say things that I I know for a
You know.
fact. So
Okay.
what we have to focus on is, do you have residual symptoms or not?
Mhm.
And because ultimately for the patient, that's what matters, right? You don't care
Mhm.
if you have a polymorphism. I mean, you care, you want to resolve your problem, your symptoms. So that's how we should work. The only thing and again, we have to eliminate other conditions. And if that doesn't explain, then we could try combination therapy.
Okay. That's great to know. All right. So just a few more questions here.
Of course.
Perfect. I wanted to ask reverse T3. Do
Okay.
you find, because I've heard you speak on this, but do you find a place? Because like I've used reverse T3, not as anything diagnostic, but more as an ebb and flow type of thing. But how do you utilize or do you utilize reverse T3?
I don't
Um,
use reverse T3.
okay.
I don't see uh, from clinically at this stage today is not very helpful. I don't think so.
Do we have a lot of studies on it?
We don't have a lot of studies on it.
Okay.
However, our research data indicates that reverse T3 is a good indicator of how well T4 is being converted to T3
Hmm.
through the other enzyme, the D1 pathway, not the D2 pathway. If the D1 pathway doesn't work well, reverse T3 goes up. So I I think that we need to do a study. We need to do a clinical trial to understand if that is clinically relevant or not. So
Okay.
in theory, if you have a high reverse T3, it could indicate that your D1 pathway is not working very well. Now, why I don't recommend this to be used from a clinical perspective, because it's not going to change what I'm going to do
Mm.
with the patient. The patient has residual symptoms, no matter what the explanation is for the residual symptoms. The only thing we can do is to combine T4 and T3. You see what I mean? If
It's
the
not going to change the medication.
Exactly. It's the
Medication.
approach
Yeah.
for that patient. We are just going to run into a lot of diagnostic tests that we don't have a lot of solid data to support. It makes sense, but we need evidence, clear evidence. And in the end, oh, okay, now I'm going to give a combination therapy. Well, you could start with that. And I think that you cut a lot of
Yeah.
headache and time from the process.
Okay. I was interested in that because, yeah, I've heard, I mean, like, I've used it to kind of keep an eye on things, but I'm curious for you. Now, okay, so I was excited to ask you this. So, what's next for you? Is there anything that you're working on now or something that you want like on the horizon in regards to thyroid hormones, anything that you're excited about that's coming forward or that you're working on for the future?
Right. I mean, I think that that's a great question. Uh, so one of my immediate focus is to understand the importance of this polymorphism.
Mm.
So we are now using stem cells in order to generate organoids, different types. We use brain organoids, liver organoids, and that have been obtained from cells with the polymorphism, human
Mm.
organoids. So I think that that will give us a real insight into what the consequences are of having this polymer. That's one of my interests. I also consult with a pharmaceutical company that is developing this long-acting T3 or slow
Mm.
release T3. There are a couple, at least two molecules that are in the pipeline. There's one in Europe. It's called T3 sulfate that provides a stable, you take one tablet per day and it provides a stable level of T3. This other pharmaceutical company also, it's called PZL, that you take one pill per day and provides a more stable T3. I think that for patients, that's going to be a good thing in order to, so you don't have to keep taking tablets during the day. And also, we'll put those concerns about the peaks of T3 to rest because so that's something I'm excited with. And unfortunately, having drugs approved by the FDA is a very slow
Yeah.
process that I'm not used to slow process. I like
Yeah.
yesterday. So
Yeah.
so that's one of the things that so these things are the ones that I'm really focused right now.
Oh, that's awesome. Well, I'm actually excited about the T3 as well. I feel like
That's
it'll
right.
be
Yes.
really nice instead of having to dose it throughout the
Yeah,
day
exactly.
and all of that. Well, awesome. Oh, and then I'm going to ask you one question. It's going to be, I didn't prepare you for this, and my good colleague does this when she interviews people. But as we wrap up here, I'm going to ask you this. If there was one book, it can be health related or not health related, it can be fiction. If there's one book that you've loved, that you've enjoyed in your life, that you would recommend my listeners check out, doesn't have to be health related, what would that one book be?
Mm,
Mm.
mm. I really like my book. The-
Okay, yeah. Listen, I really like your book too. So we're for sure gonna link your book. Well, that's number one recommendation.
Right, right. So I have to say I read that book so many times because I'm a little bit perfectionist. So,
Yeah.
well, let me read it again to make sure there's nothing stupid that I wrote here.
That sounds you
So
think like I do. Yes, I understand.
I went back and forth so many times. But in general, I read a lot of papers. I'm not, unfortunately,
That's what you do for
I
fun. You
don't
just
have
read
a
papers.
lot of time to actually my kids, they give me a bunch of books to read. I love to have them, but I have to say I focus more on the thyroid studies.
Well, listen, we'll put that as your book recommendation, and
Okay.
I recommend it too, because again, I didn't even get into, like, I thought it was just so eye-opening, the history of how
Oh
Synthroid came
yeah.
to the
Oh, that's
market.
terrific. Yeah.
Like, so I highly recommend everyone get the book just to read that,
Yeah.
because even though it's not like that anymore, that went on for decades. So it influences still today, even though it's,
Crazy.
it went about it the wrong way. It was all about money and marketing.
Crazy.
And there's one sentence, and I don't want to take up too much of your time, but you had mentioned about, like, how do we get funding, for research? And it was like, was it create I'll give you $1 million if you create $1 billion product or something like that? Like, how much being able to sell a drug was so connected
Yeah,
with funding, and
exactly.
probably still is. But thank you so much, Dr.
Okay, you're
Bianco. I
welcome.
really,
Thanks
really
for having me.
appreciate it.
It was a pleasure.
Absolutely. Hey guys, I hope you enjoyed today's episode as much as I did. I wanted to do something special because we did go over a lot of information. I want to give you guys an opportunity, if you had any questions pop up, comments, thoughts that you would like me to go deeper on after listening to this episode. Go to the website, Thyroidless Life Podcast, and I will make sure to add a link in the notes right there at the bottom, past the episode section. You can submit a question, comment, whatever it may be, and I'm going to do a follow-up podcast just elaborating on that information to make sure that you guys feel well supported, you understand this topic and how to move forward when it comes to your own health. And if you really enjoyed today's episode, I would love it if you could leave me a 5-star review wherever you listen to this podcast. By doing that, not only does it let me know that this information is helpful, but it allows me to share this information with more people.